fellow of the American College of Physicians. He has a lot of title attached to him, so I would just give him the opportunity to tell us more about himself. So Dr. Onyekachi will be talking to us about prostate cancer and all we need to know about this deadly cancer disease. So please have your questions intact because Dr. Ogbonna is loaded to give us the best. Dr. Onyekachi, you have the floor.
Excellent. Thank you, Nadozie. Well, all those accolades, I don't know if all of those are accurate, but anyways, thank you so much. I appreciate the opportunity to give this presentation on prostate cancer. As you know, a very common cancer we see all over the world and especially in Nigeria. And so I'm going to try and share my screen. Let's see if I can find my PowerPoint. Sorry, 1 second. Now, does you need some help? I'm trying to, okay, I find it now. I see it now. All right. Let's move this. All right, so go ahead and get started with the presentation. Like he discussed, we're going to be discussing prostate cancer. If people mute themselves so we don't have feedback. All right. All right, so prostate cancer, just 1 second, I'm sorry. Let's see if I can. One second. Right, sorry about that, some technical difficulties. All right, so get started with the discussion regarding prostate cancer. So we'll discuss the facts and figures, some facts and figures about prostate cancer. We'll discuss some risk factors that could predispose patients to prostate cancer. We'll discuss screening, diagnosis, risk stratification, and then treatment, okay? Right, so some facts and figures. Prostate cancer is the second most common cancer in men worldwide. And I think it's just second only to lung cancer, which is the most common cancer in men worldwide. We have an estimated 1.6 million cases and 366,000 deaths annually all over the world from prostate cancer. In the US specifically, 1 in 8 men will be diagnosed with prostate cancer over the course of their lifetime. So the incidence is pretty high, about 11%. Okay, and this incidence increases with age. So the older you are, or older patients are more at risk of developing prostate cancer. Okay. All right. So risk factors, age, like we just started talking about is one of the major risk factors. You rarely have patients diagnosed with prostate cancer before age 40, but shortly after that, the incidence rises sharply. It usually peaks around age 65 to 74, and even older patients also could get diagnosed with prostate cancer. Ethnicity also plays a role. It's been found out that people of African origin or people of African descent, Black people, have a higher incidence of prostate cancer compared to whites, Asians, Hispanics. Blacks tend to have a higher PSA, which is a screening test for prostate cancer we're going to discuss further. They have a higher Gleason score, and they have a more advanced stage at diagnosis. Family history also plays a role. If you have a first-degree family member with prostate cancer, sorry, we still have a lot of interference. If you can mute yourselves. So family history plays a role. If you have a first-degree family member with prostate cancer, that increases your risk. Also, if you have a family history of other potentially inheritable cancers like breast cancer, colon cancer, rectal cancer, pancreatic cancer, ovarian cancer, or melanoma, that can also increase your risk of getting prostate cancer. All right. Diet has been known to play a role as well. So patients that eat a diet that is very high in animal fat content, people that eat lots of red meat or low vegetable intake, all of those could portend an increased risk. Obesity also plays a role. Chronic inflammation, for example, a patient that's getting recurrent prostatitis, that can increase your risk of getting prostate cancer. Environmental carcinogens could also increase your risk for prostate cancer. All right. Screening. So this I'm going to focus on because I think this is really the entry point into the discussion regarding diagnosis. Okay, so here in the US, how it's done is the risk and benefits of screening are discussed with the physician and between the physician and the patient before pursuing screening. Because there are potential benefits, obviously. If you diagnose a cancer early, it's more likely to be curable and treated and cured. Okay, but there are also possible risks. Obviously, cost is an issue, right? It's expensive sometimes, to go through these medical procedures. There's risk of false positive diagnosis, the anxiety associated with all of that, treatment complications. So those are potential risks. So the risks and benefits are all considered before deciding upon screening. Okay. Very importantly, typically we screen patients with a life expectancy of at least 10 years because prostate cancer is very indolent. By indolent, I mean it's slowly progressing, typically. So it might take 10 years from when the cells start becoming malignant to when they become active and aggressive and causing problems. So for example, a 90-year-old, I'm not going to screen for prostate cancer because it's unlikely that the prostate cancer is going to really kill them. They will probably die of natural causes before the prostate cancer becomes concerning. So usually you screen people with a life expectancy of at least 10 years. Okay. In general, we start screening at age 50, but in people of African origin, given their increased risk or higher incidence, screening starts earlier. Screening starts at age 40 to 45 for Blacks or for Black people. Okay. And how do you screen this patient? Okay. I think you hear me now. All right. I'm sorry, I think I skipped some slides. All right. Yes. So the screening test is called prostate-specific antigen, and that's a blood test. Okay. PSA is the acronym for that. Okay. Normal PSA is between 0 to 4 nanograms per milliliter. So if you get that test done and your PSA is between 0 to 4, all good. Okay. If your PSA returns higher than 4 but less than 7, so that's an elevated PSA, it's recommended that you repeat that PSA in 6 weeks. If it's still elevated, you refer the patient to a urologist, who is a doctor that specializes in urogenital issues, and it's like the male version of an OBGYN. All right. So if the PSA is above 7, it's clearly elevated, you directly refer those patients to urologist. Okay. Yes. So there are other possible things that can make a PSA elevated. Okay. So chronic prostatic inflammation, like prostatitis. Sometimes people think even things like UTIs. And also, if you have an enlarged prostate, all of those things could make your PSA elevated. And so that's why an elevated PSA on its own doesn't make the diagnosis. You would actually need a biopsy to make that diagnosis. Okay, but an elevated PSA should prompt you to go be checked out and evaluated by a urologist. Okay, screening. How often should we screen patients? Typically every 1 to 2 years. Once screening begins, should be done every 1 to 2 years. I tend to favor 1 year with your yearly physical. Everybody should be seeing their primary doctors once a year to get regular checkup, a complete checkup. And so a PSA could be done. Just a simple blood test done once a year. Diagnosis. Okay, so you have an elevated PSA. You went to see the urologist. Urologist is concerned that there's a possibility that this might be prostate cancer. And so how do they proceed? You need tissue to make the diagnosis. You need to look at the tissue, the cells in the microscope to determine whether they're cancerous. So we obtain this by what we call an ultrasound guided needle biopsy. Okay, and so it's just a needle they're using and taking little pieces, small samples of the prostate. Multiple biopsies are obtained, typically around 12. Because it's possible that if the needle is biopsying an area where the tumor is not there, you could miss the diagnosis. So we kind of do a wide sampling of 12 cores, and that increases the likelihood of you actually detecting the cancer if it's in fact there. Okay, so if the biopsy shows cancer, there are extra things that are done. The pathologist looks at the architectural features of the cells and use that to generate what is called a Gleason score. Okay, based on the 2 most prevalent differentiation patterns in the sample. And I'm going to show you what I mean in a second. Okay, these Gleason scores are subcategorized into what we call grade groups, which correlate with the prognosis. So the higher the Gleason score or the grade group, the higher the likelihood that this cancer is actually not localized to prostate, but might have, extended past the prostate, portending higher risk disease. And I'm going to explain what I mean in this second. All right. So this is a cartoon that describes what a prostate biopsy looks like. So the patient is placed in a fetal position, all right? And just a little anatomy here. So this is the bladder where urine collects, right? And from the bladder, the urethra goes from the bladder all the way out to the exterior, right? But it passes through the prostate. So the prostate just sits below the bladder, okay? And from the prostate, into the urethra and then out. So to obtain the prostate biopsy, an ultrasound machine is inserted through the rectum. Obviously, this is a medical procedure. So an ultrasound machine is inserted after numbing the area, and a needle is connected to that ultrasound machine, and multiple biopsies of the prostate are obtained. So this is how the prostate looks like a little love shape, okay? You see multiple biopsies are obtained. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Typically at least 12 samples are obtained. Because let's say your cancer was here and you biopsied only there, you could miss it. And so that's why we kind of do a wide sampling to increase our chances of diagnosing it. Okay, so a negative prostate biopsy doesn't necessarily mean you don't have prostate cancer. And that's why we do multiple cores to make sure we don't miss the diagnosis. Okay. So this is what I was talking about earlier, the Gleason pattern. Okay, the top here, you have a Gleason pattern of 1. Those cells or those glands are small, uniform. Okay, 2, they become a little bit more spaced out. 3, as you go higher and higher and higher, it becomes less differentiated and more angry looking, for lack of a better term. Okay, so the higher the Gleason pattern, the smaller the Gleason pattern, the better it is, the more well differentiated it is. when you have a high Gleason pattern like 5, it's poorly differentiated, and those tend to be more aggressive. So the pathologist looks at the sample of each biopsy and looks at the 2 most common prevalent patterns. So maybe the most prevalent pattern is a 4, and the next most prevalent pattern is a 5. So the Gleason score will be 4 plus 5, and that's a 9. So that's grade group 5. That's actually very high risk disease. If the most prevalent pattern is a 3, and the next most prevalent pattern is a 3, the Gleason score will be 3 plus 3, and that would be 6. So that's grade group 1, which tends to be lower risk. Okay, so in general, and I'm going to discuss this in a little bit, but in general, a Gleason score of 6 or less is low risk. A Gleason score of 7 is intermediate risk. When you get to a Gleason score of 8, 9, 10, that tends to be higher risk disease. Okay, and how we approach the treatment, primary treatment, would depend on what that Gleason score is. All right, I'm going to skip this slide for a second. Okay, so risk stratification. Risk stratification is basically determining whether you think this patient has low risk disease, whether this patient has low risk disease, intermediate disease, or high risk disease. How do you determine that? First, you look at the extent of the disease. Okay, is the cancer confined to just one lobe of the prostate, both lobes of the prostate, or is it extended outside the prostate? Okay, and you don't have to get lost in this minutia. I just have this just as a guide. So if you have a tumor that is clinically inapparent, or you can't feel it, you can't palpate it, that's a T1. Okay, if you have a tumor that is palpable, meaning you can feel it, but is confined to the prostate, that's a T2. Okay, if you have a tumor that is spreading outside the prostate, it's now gone outside the prostate, that's a T3. So that's a little bit more aggressive. And you have a tumor that is not only going outside the prostate, but is now adherent or invading the adjacent structures that are next to the prostate, like the bladder, the rectum, the pelvic wall, that's a T4, and that's more aggressive. Okay. The Gleason score also factors into determining whether you have low risk, high risk, or intermediate risk, and the PSA level as well. Okay, so how does this play out? Again, there's a lot of information here and lots of specifics, but I'm going to try and make it as simple as possible. Okay, low risk disease usually is the tumor that is confined, T1 or T2A, is confined to the prostate. The Gleason score is a 6, so that's an early grade group, and the PSA is less than 10. Okay, intermediate risk is when your Gleason score is 7. Okay, PSA may be 10 to 20, sometimes they're less than 10, but it could be up to 10 to 20, and it's still confined to the prostate. A higher risk is when it's extending outside the prostate. The Gleason score is 8 to 10, the PSA is higher than 20. Okay. All right. So treatment is dependent on the risk stratification. So if you have a patient with low risk, like I said, Gleason score of 6, it's localized to the prostate, the PSA is less than 10, that's excellent. That's really as good as it gets. Okay. The options in these patients will be 3 options. We tell those patients, well, since it's very early stage, you could do active surveillance. Okay. And active surveillance would involve you getting a PSA check maybe every 3 months to keep an eye on it. If it starts rising, then you're worried, then you maybe go and do something about it then. But if it remains stable, you can continue observation. Okay. Active surveillance will also involve you doing biopsies at least once a year. So you'll be repeating that prostate biopsy every year. Okay. Who would be a good candidate for active surveillance? If I have an 85-year-old that incidentally gets diagnosed with prostate cancer, and I'm like, I don't know if I want to put that patient through surgery to take out the prostate. It's very early stage. That's the patient I may say, let's just do active surveillance, right? If it's a patient that is maybe younger, like 50s, 60s, the person has a long life ahead. So I probably want to take out that prostate as soon as possible because I don't want it to progress into something more aggressive. So a radical prostatectomy would be what I would offer for that particular patient. The radical prostatectomy basically means you're taking out the prostate in entirety. Okay. Just as good as a radical prostatectomy, you could also offer radiation. External beam radiation is delivered to the prostate and the surrounding structures in a high enough frequency to destroy the prostate tissue and destroy any cancer cells in there. So most of the patients with this early clinically localized low-risk disease, we offer mostly radical prostatectomy, taking out the prostate, or radiation. In some patients, if they are older, weak, frail, can't go undergo a surgery, we may offer active surveillance. Okay, what if you have intermediate risk disease that is localized? Again, the tumor is just in the prostate, it's not spreading outside the prostate, but the Gleason score is a 7, or the PSA is 10 to 20. Now, most of these patients, and again, there's a subdivision into favorable intermediate and unfavorable intermediate. I'm just going to discuss it as intermediate for our purposes, so we don't get into the weeds. So for intermediate risk disease, most of the times we would offer those patients radical prostatectomy, meaning taking out the prostate and also lymph node dissection. So when they take out the prostate, the surgeon also takes some lymph nodes in that area to make sure that it hasn't spread to the lymph nodes. Because if it has spread to the lymph nodes, then it's more aggressive, okay? Because from the lymph nodes, then it can spread to other parts of your body. It can spread to your bones, to your liver. Then you have what we call metastatic disease, which is no longer curable, okay? So when the surgeon does a radical prostatectomy for intermediate risk disease, they also biopsy some lymph nodes to make sure, to confirm that it hasn't gone to the lymph nodes yet, okay? Alternatively, instead of the surgery, you could go for radiation as well, high beam radiation. But in these patients with intermediate risk, in addition to the radiation, they give them about 4 to 6 months of hormonal therapy called ADT. ADT stands for androgen deprivation therapy. Since prostate cancer is fed by testosterone, right, which is the male hormone, right? Like you have estrogen for women, for men is testosterone. What you do is that if you basically give medication that suppresses testosterone. And if you're suppressing testosterone, you're starving off the prostate cancer cells. So alternatively to surgery, you could give radiation with 4 to 6 months of this hormonal therapy, and then you're done. Okay, so that is typically how we treat intermediate risk disease. What if you have a cancer that is still localized to your prostate, but it's higher risk, meaning the Gleason score is a Gleason score of 8? Okay, in these patients, the main thing you go for, there are 2 options, but the main option, which we give like 90% of the time, is radiation, external beam radiation to the prostate and surrounding tissues, plus the same hormonal therapy. But in this case, we give hormonal therapy longer, for about 18 to 36 months. All right. In some patients, some select patients, we may give surgery, but typically that's not what is, because the risk of you having it spread to lymph nodes and surrounding tissues is higher when you have a Gleason of 8. So typically we go with radiation and hormonal therapy, okay? Because you may do a surgery and that surgery may not get everything. Or after surgery, if there's still residual disease, you may still need radiation, okay? Now, what if you have a cancer that is very high risk, meaning the cancer is not localized to the prostate, it is extended outside the prostate and has a high Gleason score, of 9 or 10. These patients, you would still offer radiation therapy with 18 to 36 months of hormonal therapy. All right, last slide on treatment. If you have what we call, so if the cancer for some reason has gone to the lymph nodes, right? We call that stage 4A disease. It's not necessarily metastatic. When I say metastasis, I mean distant spread to other organs. Okay, so if it has gone to lymph node that is around the prostate, it's not yet metastatic, but it's still considered stage 4 disease. In these patients, you will give radiation treatment and you will also give hormonal therapy, just like before. You might extend that hormonal therapy for a little bit longer because you have lymph node involvement. In patients that have stage 4B disease, now this cancer has really gone crazy. It's gone to the bones or to the liver or lungs or brain, then you have an incurable cancer. Unfortunately, many cases I've seen in Nigeria, patients get diagnosed very late. And that's why this discussion is being had about early detection and screening. So many patients I've seen in Nigeria have diagnosed when it's already spread to the bones, to the liver, to the lungs, then you no longer have a curable cancer, okay? But that doesn't mean that the person is going to die tomorrow. No, we have treatment options that are available, But the goal of treatment is not to cure it. The goal of treatment is to shrink these tumors as much as possible, okay, or keep them stable or slow their progression and allow the patients to live, extend the patient's life. I've seen some prostate cancer patients where, depending on how aggressive the disease is, when it's metastatic, even with treatment, they may live 1 year, 2 years, 3 years. But I've seen some other people that have gone 8 years, 9 years, with treatment for metastatic prostate cancer, and they're still alive. Okay, so it all depends on how aggressive it is and the particular circumstance. For metastatic prostate cancer, the main backbone of treatment is this hormonal therapy, the androgen deprivation therapy I talked about. And all that does, again, is gives the medication that suppresses testosterone. Okay, if the patient has extensive disease on diagnosis, we sometimes add, most of the time, we add some chemotherapy upfront, not forever, but about 6 cycles of chemotherapy upfront to shrink the cancer quickly, because that's been shown to prolong their survival if you do that, as opposed to just hormonal therapy alone. So once they're done with the chemotherapy and, once they've gotten the 6 cycles of chemotherapy with the hormonal therapy, you continue the hormonal therapy. And then you see those patients continuously, checking in on them. And when I say you see them, you're examining them and you're doing a PSA every few months. If the PSA starts rising or they develop new spots or new spread, then we may need to switch to another treatment. And there are many other treatment options available. And we'll keep going basically until we run out of options. So metastatic prostate cancer, you're going to be on treatment indefinitely, basically until there's no other treatment to offer. Let's see. Yes, and when you have metastatic cancer patients, in addition to a PSA, which you'll be checking every few months, you would also be obtaining CT scans and bone scans, maybe every 3 to 6 months, to make sure that you're keeping an eye on things to determine when they develop new metastases. Okay, one last thing. Patients that have bone metastases, we give some medication that helps to prevent osteoclast activity. By that, we give medication that helps to prevent bone destruction. So one of those category of medications is called bisphosphonates. Another is called rank ligands. One of the bisphosphonates that's very common is zoledronic acid. One of the rank ligands that's very common is Exgeva. So those medications are given to prevent this cancer in the bones from causing bone destruction and causing fractures and stuff like that. Okay, so that's given concurrently with the systemic treatment. Okay. So androgen deprivation therapy, I am not going to go into the weeds on this. It's just saying that it's hormonal therapy that is a medication usually that fights prostate cancer by suppressing testosterone. Okay. Another form of androgen deprivation therapy, which we usually don't do, is a surgical androgen deprivation therapy. And that is what we call an orchiectomy. So basically, if you take out testicles, they do surgery to remove the testicles. It's basically a surgical castration, and that way you suppress testosterone. But most of the time, what we do is just do it medically. So medical castration is by giving, suppressing your testosterone with medication. Okay, but either of those are valid options. The medication from just seems more humane, I think. Right, I have a video here about what a radical prostatectomy is, just so that you can get an idea of what it looks like. In the US, it's usually done robotically. Back in the day, there was no robotic option, so you did it just by open surgery. And obviously, with an open surgery, a wide incision, there is it's a longer healing process. So these days, we do it laparoscopically with the help of a robot, so it's less incisions and patients heal very quickly. Okay, and also the robot is just easier able to maneuver the procedure than human hands. There's only so much you can do by hand. So I'll show you this video to show you how it looks like. A robotic assisted radical prostatectomy.
You have been diagnosed with prostate cancer. Your doctor has recommended you to undergo a robot-assisted radical prostatectomy, or simply RARP. A radical prostatectomy is a surgical procedure where all of your prostate is removed. This animation shows how the procedure is done. RARP is carried out under general anesthesia. During a general anesthetic, Medications are used to send you to sleep, so you are unaware of the surgery. When you are fully sedated, small cuts are made in your belly. Surgical tools and a camera are inserted through these cuts. The surgical tools are attached to the arms of a robot. These arms are controlled by the surgeon with a console, which is placed next to the operating table. The surgeon detaches the prostate from the surrounding tissue. The seminal vesicles, two small fluid-filled sacs next to your prostate that secrete fluid which partly composes the semen, are also detached. Sometimes the lymph nodes, commonly known as glands, are removed also. The surgeon will take care to cause as little damage as possible to the nerves and blood vessels surrounding the prostate. The prostate and seminal vesicles are removed from the body through one of the cuts in your belly. The bladder and urethra are now sutured together. Robot-assisted surgery provides a clear visualization of even the smallest parts in your body. A catheter is inserted in your bladder to help the stitched-up wound to heal. The catheter removes urine from your body. You will be wearing it for a period after you have left the hospital. It will remain in place by inflating the balloon at its tip. RARP is a major surgery from which your body needs to recover. You will suffer for a while from urinary incontinence, which in most cases is temporary. You may also suffer from erectile dysfunction after the surgery. Talk to your doctor about what can be done to overcome these complications.
All right, so I'm going to conclude the discussion by highlighting some main points. The first is that prostate cancer is the second most common cancer affecting men worldwide, and it is more prevalent in African Americans. So some of these guidelines, some of these discussions we had is based on the US system, but the US is very heterogeneous, right? It has people of different races. So here in the US, the screening there's no generalized screening. You basically discuss with your doctor about risks and benefits before pursuing screening. But I feel like in African societies, especially like places like Nigeria, where the population is all Black, Black people have higher incidence of prostate cancer, I feel like screening should be more emphasized, and perhaps screening should be offered more, generally. Obviously, there are risks of screening, but I feel like the benefits outweigh the risks. Obviously, this is an individualized decision that should be made with the physician and the patient, but I think physicians should offer patients the opportunity and discuss with them, especially primary care doctors should discuss with their patients prostate cancer screening. I think screening in general in Nigeria for different cancers is not as robust as it could be. And since this is a generally easy screening test, just a blood test, I think we should focus more on doing that. And if a PSA is found to be elevated and persistently elevated, it is very important that patients see a urologist and that they pursue biopsy, because that's the only way you're going to detect it. If you detect prostate cancer early, you detect it Gleason 6, Gleason 7, you could achieve a cure, you could live the rest of your life, pretty good. But if you discover it when it's already advanced and progressed and metastatic, then it's no longer curable. And then you just give treatment to manage it as best you can. But early detection is really, really important, especially for people like us that have increased risk for prostate cancer. All right, I think I'm going to open up the floor for some questions. Any questions at all? Let's see.
Thank you, Dr. Onyekachi.
You're welcome. Okay, I see some questions here. I guess I'll just go.
I have a question.
Oh, sure, go ahead.
Yeah, this is Onyekachi. I wanted to ask that at what age would you advise us to start start running the test? Because I see you said from 40.
40 to
The
45.
from 40, exact. So we should. So even if you're like 35, 36, 38, 39, you shouldn't worry about testing for now.
No,
Just wait.
not. Yes, typically the incidence in people less than age 40 is very low, so I wouldn't do it before age 40. But if you have a family history, let's say you have you have an uncle or you have your dad, God forbid, but let's say your dad had prostate cancer at age 45, then I would start testing at age 35. I'll start testing 10 years before the earliest family member was diagnosed. Okay, but if there's no family history of that, then I would start regular screening at age 40 to 45.
Okay, what if the cancer is on the female side of the family, like the mother side?
Okay, like breast cancer or the other one, then I would just
like ovarian cancer,
yes,
like on the mother side.
Yes, I would just start at age 40 to 45 in that
Okay,
yes.
Okay, thank you.
You're welcome. All right, I see another question here saying, someone said crazy video. Oh, it seems crazy looking, but it actually is better than the open procedure because, like I said earlier, patients recover faster. Just small incisions, right? Those robotic arms are being controlled by the doctor. It's almost like a video game so to speak, but it actually has smaller incisions, patients heal faster, and recovery is quicker. Somebody asked, let's see, sorry, read this question. Is the PSA blood testing a specialized test, or is this something that can be tested at regular labs? I'm not certain how the situation in Nigeria is. Here, it's a regular test that anybody can offer. I think actually you should be able to, I think any primary doctor, I think most labs should be able to have it. Yeah, I don't know necessarily about the situation in Nigeria, but here it's a basic test that anybody can order. What are the symptoms generally? Okay, so since we're discussing screening, right, patients might not have any symptoms, right? You really don't want to wait until you have symptoms, because if you have symptoms, it means that you might already have an advanced, case. Okay, in patients that have advanced cases, the symptoms they would have would be they're having urinary obstruction. Usually those patients also have an enlarged prostate. So they're like, oh, when I go to the bathroom, I can hardly pee, or it takes forever for me to be able to start a urine stream. Or I feel like I go to the bathroom and my bladder isn't fully emptied and I have to go back every 2 hours. I'm going to go pee and I feel like I'm not emptying out my bladder. Or, oh, I'm seeing blood in my urine. That's a bad sign. Or I'm waking up at night like multiple times to go and pee. That we call that nocturia. Or, oh, it burns when I pee. So there's lots of options. Urinary obstruction usually are the symptoms that patients will present with when they have an enlarged prostate. Some people that have an enlarged prostate don't have prostate cancer, but a urologist will help figure that out by getting the biopsy. Okay, but for us, for our purposes, we're not really talking about waiting till then. We're discussing screening and getting tested early so that it doesn't even get to the point. I've seen many patients that get their screening and they diagnose the prostate cancer when they don't even have any symptoms at all, right? And that's what you actually want, so that you can take care of it early before it becomes problematic. I think somebody was raising your hand. You can unmute yourself and ask your question.
Yes, thank you, doctor.
Okay.
My question really stems back to what you mentioned earlier, that it's more likely to occur in Black people or people of African descent. Could it be something to do with our diet, or is it just a cultural thing or an evolutionary thing? I don't know if there's any scientific backing for that. Yeah.
It's not really clear why the case is. Unfortunately, it's not really clear why that is. But it's just, I guess it's just, there's some illnesses that are more prevalent in certain populations. And who knows, maybe it's like an evolutionary thing, right? Just like Africans have sickle cell trait, right? I think we had that discussion on one of our last webinars, and that was an evolutionary mechanism to protect against malaria, because the people that have the trait tend to do better than those that have normal AA genotype. And so maybe we don't know exactly why that is, but unfortunately, people of African origin have a higher incidence.
Okay, no, thanks, Doc.
You're welcome. And let me see, there's another question here. if one takes out their prostate, how likely is it to affect their sexual drive or performance? All right. So yes, there is high incidence of erectile dysfunction after prostatectomy, because all those nerves and things around there could be transected during the surgery. The good thing about doing it robotically is that there's a better view for the surgeon, and so they can try to do what is called nerve sparing. Okay, so they can see a little bit easier, and then they can try and actually spare some of those nerves when they're taking out the prostate. But there is a significant incidence of decreased erectile dysfunction after that. It wouldn't necessarily affect their sexual drive, I think. They may just have issues with maintaining erections, because the sexual drive is driven by testosterone. So, and if you're not taking hormonal suppressive agents, I don't think that would be affected. The issue is usually the erectile dysfunction. Next question says, if prostate cancer is localized, is there a possibility of having a partial prostatectomy as opposed to a radical prostatectomy? Nope, they can't take out part of it. It's just all or nothing. So they usually just take out the whole prostate. All right, let's keep the questions coming, either on the chat or in person.
Hello, Doc.
Hi.
Can you hear me?
Yes, I can. Go ahead.
Okay. I actually watched the video, man. It's scary. Well, I have a very simple question coming from the side of a layman.
Okay.
So I know in basic biology, I know the prostate gland actually secretes a fluid that supports reproduction, that protects the sperm, something like that, right? So now, looking at a particular method of treatment that has to do with radiotherapy, where you use what's it called?
Radiation.
Use radiation, exactly, to bleed off these cancer cells.
Mm-hmm.
So I'm just thinking, does it actually get rid of the entire reproductive process? And
no.
Secondly, when
Sorry, go ahead.
And the second question is, so when we cut off that prostate, right, from that video, is there still possibility of, will it affect the entire reproduction? So I'm more concerned about reproduction.
I see. Understood. Well, that's a very good question. So let me see if I can remember. The first one was basically, the first question was, sorry, remind me just briefly what the first one was, the first question.
Yeah, the effect of the radiotherapy, when bleeding of the cancer cells, will it also affect
reproduction?
The prostate? Yes.
Or reproduction? No. Now, the issue is that when your prostate gland is removed, right, you may have issues with erectile dysfunction, but not typically reproduction, because they're not targeting your testes, which are further down, right? It's just the prostate. So no. Yes, if you are getting chemotherapy and stuff, there's increased risk of becoming infertile after that, but not to my knowledge with radiation. No, the incidence of infertility after that is not high.
Okay, thank you.
And then the second question you asked.
When you cut off that prostate, sorry, not you cutting it off from that video.
Yes, I understand. Yeah.
So okay, will it still affect infertility? Because I know it's supposed to.
I mean, there could be, yes. So the prostate gland secretes, helps to secrete stuff to preserve sperm, right? It secretes fluids. Also, in that video, you saw that the seminal vesicles, which contribute a lot to semen production, are taken out. So yeah, there could be some decreased. Yes, I would say yes, there will definitely be some. How I put it, I don't rule it out that the person can't have children anymore, but definitely there will be some decrease in the in fertility. But usually these people will not be. Yeah, exactly. May not be as
the sperms will have less security.
Exactly, but most of these people that are diagnosed are in their 60s and stuff. So usually they're already done with childbearing, and yes, the answer to your question is that yes, there could be an effect on fertility. But for most people that are diagnosed, it's rare you see people being diagnosed so early. For most people that are diagnosed, they're really actually done with having children.
Okay, I think that's yeah, you've answered it. Thank you so much, Doctor.
You're welcome. Let's see. Okay, I think I answered all the questions on the chat. More questions, please keep them coming.
Yeah, I got a question, Doctor.
All right.
Yeah, I know you talked about taking out the prostate, and you talked about not maybe not being able to, reproductive wise,
Yeah.
might not be able to impregnate a woman and all of that. But and I feel like according to the way God designed the body, there's a balance to everything. Once you take something out, it's like you're messing up with the balance. So it's like, so if you take out the prostate, do you have to be like on a medication for life, or what do you have? What goes on after that?
No, you don't need anything. The prostate really is just an accessory organ, right? That helps to like maintain like semen production and maintaining sperm, right? That's really what it does. So you don't really need to replace it. Like, I know what you mean. I think you're talking about certain organs, like you take out your thyroid gland, you need to take thyroid replacement hormone. You don't need to take anything.
Something like that.
No, you don't need to take anything for once you remove the prostate. It's just out and it's fine. You don't necessarily need it. The only thing is regarding the erectile dysfunction we were talking about before, the medication, as you guys know, that can be given to help, improve that. So there are medications like we're giving Viagra, Cialis, there are medicines available to help with that. And I've seen patients that actually have had prostatectomy and tell me, oh, everything was fine. I didn't really have any problems. Okay, so the surgeons try as much as possible to do nerve sparing when they do the surgery so that things are preserved. It might decrease somewhat. I mean, every case is different, but yeah.
Yeah, you said earlier on, you said that once it gets to the lymph nodes, then it affects the bones, then there's nothing you can do anymore.
No, once it gets to the lymph nodes, once it gets to the lymph node, it is considered stage 4, but it's not organ metastatic. Okay, so you can still potentially cure it. There's a high likelihood of it coming back when it's in the lymph nodes. Okay, but when it's gone from the lymph nodes, so usually how cancer goes, it goes first from the primary side to the lymph nodes. From the lymph nodes, then it branches and then spreads to other areas. Okay, so the lymph nodes is kind of like it's the branching point where it then can become metastatic from there. So in the lymph nodes alone, it's still possibly curable. When it's gone to different organs, when it's gone to your bones or your liver or your lungs, that's when we say it's no longer curable. But in the lymph nodes alone, it is still potentially curable, although with a high risk of recurrence.
Well, I want to say thank you for this video, because I had a friend who lost the dad to prostate cancer, like I think sometime last year, and that was even before I met you at this place.
Yeah.
And sometimes I wish we have all this information readily available.
Exactly.
Before when these things happen, because you go to some doctors, they don't even tell you all these things. You go see a doctor, they want to talk to you for 10-15 minutes and be done with you. But but this is really nice. I really appreciate what you're doing.
You're welcome. My pleasure.
Thank you.
My pleasure. Yes. I think yes. Early detection is key, because if you get it early, right? If you do a PSA, you find out it's elevated, you get the biopsy, if the cancer is diagnosed, then you discuss your options about treating it. Early detection is key, because if you detect it early, you could cure it.
Hello, doctor.
Yes, sir.
Yeah, please. I joined quite late. I don't know whether you must have answered this, but I want to know, what will you consider the best way to remove the prostate?
Okay. So the best way to remove the prostate is the robotic prostatectomy we discussed. But again, it depends on what is available at your area of residence. I'm not certain everywhere has the option of doing a robotic prostatectomy. Some places might just have the routine, like the standard open prostatectomy, which is where, actually the surgeon does a large incision and opens up the area and takes out the prostate. So that's also an option. The key thing is really just getting it taken care of. But any urologist should be able to do a prostatectomy.
Yeah, but
yes,
the one you talked about is open surgery, right?
Yes, they are all open surgeries. They're all open surgeries. The only difference is that this one is a smaller incision, right? And it's just tiny little cuts, and then those robotic arms are then inserted. It's what we call laparoscopic. That's the big medical term for it. Whereas the standard way of doing it way back when there's opening up the abdomen and then going to finding the prostate and then taking it out. So that's obviously a larger incision and takes, maybe more recovery time. It may take longer to heal from that procedure as opposed to, the robotic option. But again, if I don't know where you're based, if you are based in an area where they have the robotic option.
I am based around Ibadan.
Okay, so in Nigeria, I'm sure Nigeria probably, I'm not very familiar with the infrastructure there, but I'm sure there are areas in Nigeria where it might not be commonly available, but I'm sure there will be areas where this robotic prostatectomy is being offered.
Because the fear usually is after the post-surgery effects.
Recovery, yes.
Yeah, recovery, and then incidences of, various levels of complications, and no man wants to spend so much money cutting himself up and then dripping.
I know. Oh, yes. You're talking about some of the post-surgical complications. So yes, there is a risk of some incontinence, urinary incontinence, or some leakage. It's not like major, like just dripping urine, but there could be some leakage after the surgery. But usually that lasts maybe weeks and resolves over time once there's full healing.
I once heard of a specialist in, I think is affiliated to Mayo Clinic in the US, who uses steam. Have you heard about that?
Uses what?
Steam, heated water technology.
I've not heard of that, no.
Okay.
I haven't heard of that.
Okay.
You sure it's steam? Maybe it's something else.
Okay. No, it's steam. There is another development in the, I think it's the nation of Israel, where they use freezing.
Cryotherapy.
Yeah. So that these are ways by which I think they reduce the complications that we're talking about, which I guess are the things that we lack in Africa.
No, the standard treatment here that's offered is just this surgery. I guess there may be experimental therapies that are in development, but not that I'm aware of steam technology. Okay. Just 1 second. Sorry.
Hello, doctor, please, where are you based?
I'm based in the US. I'm in Portland, Oregon.
Okay.
Yes.
Okay. So this one I talked about, I read it in the US. Okay.
Yeah. So,
hello, doctor, I have a question.
Sure, go ahead.
I have a question.
Okay. Okay, let me.
So,
go ahead.
Okay, thank you. For younger folks like us, within the range of late 28 to late 20s to early 30s, the best form of treatment is early detection, right? And
yes, correct.
So I'm just thinking, do you have an idea of the cost implications for this diagnosis? So maybe we can start planning ahead in dollars. Well, I'm based in Nigeria, so I can include it to my insurance, so because I think that the best way to go about it is early detection. I don't have to wait till I'm 40 or yeah.
Understood. The cost is the US medical system is very complicated, and the cost of a procedure like that are usually paid by insurance. So most patients here, or most people here, have medical insurance. So they pay premium, and then when they get sick, the insurance pays for most of these things. Paying out of pocket, I feel like sometimes the costs here are kind of falsely elevated, or like they're kind of like overbilled or overcharged. And then, so if you have to pay for it by yourself, it's kind of exorbitant. Most people don't have to pay full price because insurance covers it. So I think having a prostatectomy here in the US the cost may be like $50,000. It's just ridiculous, actually. Obviously, people that have insurance don't have to pay all that amount, right? Because insurance covers most of it. I think it could be a lot more affordable in other areas. The US medical system is just a little bit,
Hello, Doc.
Yes.
Hello, Doc.
Yes.
Okay. So I think we have actually run out of time. So yeah.
Okay.
So I think we
Can
just
you let me ask a quick question.
The last. Yeah. Okay.
Let's take some few questions.
Okay.
Doc, my name is John. I'm in Nairobi, Kenya.
Okay.
And I want to ask, can a condition in prostate cause weak muscles?
What do you mean by weak muscle?
Weak muscles in the sense that you have an enlarged prostate.
Uh-huh.
And you have a 20.
Do you mean like an
and
erectile?
You have no. Muscles on your thighs and on your hands. You end up with weak muscles on your thighs and on your biceps, for example.
I see. So if you have prostate cancer that is not treated and it's progressing and it's metastatic, you can have a lot of symptoms, systemic symptoms. You can have body aches, weakness. I've seen patients with metastatic prostate cancer, generally weak, can't get out of bed. It can cause like because it's a systemic illness at that point. So people that have cancer usually can have fevers, night sweats, weight loss, massive weight loss, like 50 pounds of weight loss in a year. They can be very tired, very fatigued, weak all over. So all of those are systemic manifestations when you have, metastatic disease. And obviously, if it's involving your bones, then you can have bone pains as well, right? If it spreads to your soft tissue of the muscle, you can also have muscle pains. So yes, that is definitely possible from prostate cancer. But localized prostate cancer on its own, when it's just localized to your prostate, typically wouldn't cause those symptoms.
Okay. Thank you.
Right. A few more questions, I think. Let's see.
Okay. Thank you very much, Dr. Onyekachi.
Oh, sorry, one more thing. Sorry, before we. Somebody asked a question about radiation instead of surgery in Nigeria. Getting radiation treatment in Nigeria instead of surgery. I don't know. I think the infrastructure is I'm not sure exactly how what the Nigerian infrastructure is, but I think radiation there might be challenging because it's not as robust. The infrastructure is not as robust. And radiation, if you're getting radiation, I didn't discuss what that involves. Radiation for prostate cancer instead of surgery. Surgery is a one-day thing. You go in, you get the surgery, you're done, right? Radiation is actually typically external beam radiation therapy. So every day you get radiation for like 30 days. Okay, so Monday through Friday for like 6 weeks, you get radiation to that area. The radiation is just takes a few minutes, but I don't know if there's the robust infrastructure to be able to allow one patient get 30 radiation treatments daily like that, over that course of time. So I feel like surgery is probably the easier option to offer in Nigeria than radiation, just because of infrastructural constraints. All right. Thank you guys so much. This was really, thank you all for your audience. Thank you for the opportunity to discuss this with you, and I'm looking forward to more.
All right. Thank you very much, Dr. Onyekachi. This was fully packed and informative. And I want to thank everyone that made it to this Diagnostar free webinar series. This is, like I said before, this is the second in the series. And we have more webinar series coming your way. So please make sure you follow us on our Facebook and our Instagram handle, Diagnostar Healthcare. On Instagram, Diagnostar Healthcare. On Facebook, Diagnostar Healthcare. And then we'll have a recorded version of this on our YouTube channel. Just go to YouTube, Diagnostar Health, and you would see a recorded version of this webinar. Also, subscribe to our YouTube channel so that you can see upcoming webinars as well. So to wrap up, I'm going to leave the floor for our founder, Joe Philip Zanwa, is going to wrap up with a few words. Joe. Hello?
Hello, can you hear me?
Yes, we can now.
Yes, we can hear you now.
Sorry. I just wanted to thank Dr. Onyekachi Ogbonna for taking time out of his busy schedule. A doctor of his caliber is very busy. So we thank you for taking time to educate us on this very common and deadly disease, and also ensuring that we are able to get ahead of our health and be on the lookout for this and make sure that we prevent this from happening to us and our loved ones. So this webinar has been powered by Diagnostar Health. Diagnostar Health is actually a platform that gives access to healthcare services and for you to access providers or physicians like Dr. Onyekachi and the likes. Dr. Onyekachi also, we are fortunate to have him as our Chief Specialist Officer. He's one of our lead medical management team. So you could always access him through diagnostar.com. We have a lot more of these webinars coming your way, very useful. And we're hoping that you will continue to follow us and keen to our platform to access doctors like Dr. Onyekachi and the likes. So thank you all for being part of this webinar. Again, go to diagnostar.com, read about us, and also set up your profile, have your medical record strong and handy, and start to utilize what we have to offer. Thank you again, Dr. Onyekachi. Thank you all for being part of this.
Okay, thank you. All right, so thank you, everyone. Thank you once again. Have a great weekend.